Hello, everybody. Good evening from Manila, Philippines. Good afternoon, good morning, wherever you are on planet Earth. I'm Renzo Ginto. I am the Chief Planetary Doctor of PH Lab, which is a local think and do tank for advancing the health of both people and planet, and also Associate Professor of the Practice of Global Public Health and Inaugural Director in the new Planetary and Global Health Program at the St. Luke's College of Medicine in the Philippines. And I will be your moderator for today's parallel session entitled Climate Changes Health, Emerging Disease Trends for Reorienting Health Services. So today we have five amazing emerging and scholars and practitioners from around the world, from different continents, who will share their research projects at the nexus of climate change and public health. We know that climate change is anticipated to exacerbate a wide range of disease conditions, and therefore health services will need to be ready to respond and to tackle these novel disease trends. And that is why today, again, as I've mentioned, we have exciting projects that will be presented in this session. And just to guide you all, I know we're all still trying to master the platform, which is fantastic. We're able to still hold our conference, albeit virtually. There are buttons that maybe you should begin to get familiar with. There's a live support button. If you have some technical issues, feel free to use it. But also, I would encourage all of you to ask your questions or even provide your feedback, your insights using the live Q&A button. And I will be keeping abreast of what you input there so that later on during the Q&A, we can ask these questions or share your comments to the panelists. And there are also other reminders there, as you can see on your screen. The sessions are recorded. They will remain available until March 2021 to all of you, to all of those who are registered in this conference. And so let's begin. Let's cut to the chase. And I would like to call on our first presenter. He is Sia Agre, a PhD student at the DSI NRF Center of Excellence for Invasion Biology, Department of Botany and Zoology at the Stellenbosch University in South Africa. And he will be presenting his paper, Bayesian Network Modeling Applied to Dynamics of Health Systems in a Malaria Climate Change Setting in High Altitude Areas in Uganda. So let me give the virtual microphone to Sia.
Hi, my name is Sia Agre. I'm a PhD student at Stellenbosch University. I'm presenting my work on the Bayesian network modeling applied to the dynamics of health systems in a malaria climate change setting in high altitude areas in Uganda. Malaria affects more than 200 million people worldwide, with the highest morbidity and mortality in Africa. In the high altitude areas of East Africa, there has been spatio-temporal variations in malaria, with climate change pointed out as one of the contributing factors. The malaria belt in Uganda is expanding, especially in the high altitude areas of Uganda. However, information on the dynamics of health systems and human livelihoods has been limited. So this study sought to use the Bayesian network modeling to elucidate the complex epidemiological data from health systems in Kween district of the high altitude areas of Mount Elgon in Uganda. So in this study, I undertook it in Kween district, one of the districts in Uganda, in East Africa. So it's located in the Mount Elgon areas. So I got data on climate variability, malaria incidences, and household interventions to address malaria within the communities in this district. Then I used the Bayesian network modeling analysis to understand the dynamics. So this is a representation of what came out, how different variables are connected within this area. So we found out that enhancement of household income and enhancement of the adaptation strategies are two actionable factors that are directly associated with people's interventions to the malaria incidences. Then household income is also associated with the type of housing, while expenditure on malaria is associated with interventions applied in this area to address malaria. We also found out that climate variability is associated with the number of households, but not directly with the household income and malaria interventions. The malaria incidences and climate trends data are particularly well suited exactly for network modeling approach as systems are involved as well as households. Moreover, multiple factors which are potentially interrelated are at stake. The nice natural future of the Bayesian network modeling to efficiently deal with co-founders and collinear factors is especially useful in such a situation to disentangle directly versus indirectly related variables. Malaria interventions thus ought to be designed to leverage household income in such high altitude areas. This should be done while enhancing adaptation to climate change. Thank you so much.
Thank you very much, Sia, for your presentation. And now from Uganda, let's fly all the way to Mexico. And we have with us Roberto Ariel Albeldaño. He is a full professor at the postgraduate department of the University of Sierra Sur, Oaxaca, Mexico. And he will be presenting his paper entitled Trends in Climate Change and Mortality Attributable to Environmental Problems in Latin America and the Caribbean. So Ariel, please, you may begin.
Well, good morning. Thanks to the organizers for the possibility of sharing our study. We are Diana Lopez Cruz and Ariel Abeldaño from the University of Sierra Sur in Mexico. And now we are going to present the results of our study, Trends in Climate Change and Mortality Attributable to Environmental Problems in Latin America and the Caribbean. The main consequences of climate change affect directly the health of populations. Climate events affect food and water supplies, changes the distribution and emerging of infectious diseases, and also there is evidence of the association of non-communicable diseases with climate events. So the aim of this study was to analyze trends in climate change and mortality attributable to environmental causes in Latin America and the Caribbean between 1990 and 2017. The methods: it was an observational, descriptive, and ecological level study. We analyzed 33 countries of Latin America and the Caribbean region with data sets that are available for public access from 1990 to 2017. Our study includes three dimensions. The first dimension is climate change, the second is related to disasters, and the third dimension is mortality attributable to environmental conditions. The first dimension includes these variables: temperatures, rainfall, CO2 emissions, and percentage of forests, of lands destined to forest. The sources of data were the Meteorological Institute of the Netherlands, KNMI, the World Bank, the Emissions Database for Global Atmospheric Research, also known as EDGAR, and the Food and Agricultural Organization from the United Nations. The second dimension, disasters, includes these variables: climate-related disasters, deaths, injured people, affected people, and homeless. This is a variable that includes the people who lost their home due to a disaster, and economic damage. This variable came from the MDAT database. This is a database developed and sustained by the Université Catholique de Leuven from Belgium. And the last dimension, the mortality, includes two variables: the mortality attributed to indoor and outdoor air pollution, and mortality attributed to unsafe water services. This variable came from the United Nations Development Program. The results. In the results, we can see an increase in two variables, CO2 emissions and temperature, and a decrease in the other two variables, precipitation and forest cover. The increase in CO2 emissions affect mainly countries like Mexico, Brazil, Argentina here, and Venezuela here. The temperature variable affect countries in Central America and the Caribbean. And the precipitation, the decrease in precipitation and forest cover affect the countries in the Central America and the Caribbean region. Regarding the incidence of disasters in Latin America between 1990 and 2017, we can say that Argentina, Brazil, Cuba, and Mexico were the most affected countries. And here we analyze the deaths, the injured people, the affected people, the homeless people. This is the people who lost their homes due to disasters, and the total affected people. This variable is the result of the sum of the injured people plus the affected people plus the people who lost their homes. Here, in the total affected people variable, we can see that Brazil recorded more than 50 million total affected people. Cuba recorded more than 22 million of total affected people, and Mexico recorded more than 14 million of total affected people. The same pattern here is shown in the variable related to economic damage. Regarding the mortality attributable to environmental conditions, the analysis includes two variables: mortality rate attributed to indoor and outdoor air pollution. It was calculated per 100,000 inhabitants. Also, the variable mortality rate attributed to unsafe water conditions, calculated per 100,000 inhabitants. This variable has data available only for 2016. There are no more available data. And here we can say that the most affected people were Belize, Bolivia, Guatemala, Guyana, Haiti, and Honduras. The conclusions. We can conclude that in Latin American countries, this process shows an increase in temperatures and CO2 emissions, with a decrease in precipitation trends and land destined for forests. Regarding the climate change, the most affected countries are Argentina, Brazil, Cuba, and Mexico. Regarding the mortality due to environmental conditions, we can conclude that the most affected countries were low-income countries like Bolivia, Guatemala, Haiti, and Honduras. The data for assessing trends in mortality are not available. There is only available 1 year data. And we can recommend to strengthen local health systems to reduce mortality and morbidity in the most vulnerable populations in Latin America and the Caribbean, as well as to create monitoring systems to access data in the field. Well, this is all. Thank you. We are now open to hear your questions.
Thank you very much, Ariel, for that presentation. Before I call on the next speaker, I would like to encourage our participants to please keep on sending your questions and your comments using the live questions or live Q&A chat box in the platform. So really looking forward to your questions and inputs later on. And so now let's go back to actually where I'm right now in the Philippines, and let me call my compatriot, Anne Kathleen Baladad. She is a research associate at CICAR PH and a Master of Geography student at the University of the Philippines in Diliman. She's also a collaborator of Epimetrics Incorporated, and she will be presenting her project entitled Assessing and Projecting Climate-Related Infectious Diseases in an Urban City in the Philippines. Anne, please, you can start. Thank you.
Hi, my name is Kathleen Baladad from Manila, and I'll be presenting our climate and health study on assessing and projecting climate-related infectious diseases in Quezon City, Philippines. Now, this project was part of a much bigger project called Coastal Cities at Risk in the Philippines, or CICAR PH. So it's a collaboration among different institutions, namely the Ateneo de Manila University, Manila Observatory, National Resilience Council, and selected local governments. It's a transdisciplinary action research project involving decision makers and experts from different fields, working together towards building resilience to climate and disasters in the Philippines. This particular sub-project focuses on the health aspect of climate resilience. And given our resources, we were able to conduct a study on 2 infectious diseases in one urbanized city. As such, we wanted to find out the burden of infectious diseases, in this case, dengue and leptospirosis, associated with a set of climate indicators. Now, for reference, I'll be using the following abbreviations throughout the presentation. So why dengue and leptospirosis? Both are infectious diseases with numerous studies showing their association with climate indicators. Now, dengue is most commonly transmitted by the Aedes aegypti mosquito, which mostly grow in urban areas and man-made containers, contracting the infection in virus-contaminated water. Now, leptospirosis is a bacterial infection most commonly carried by rodents and other mammals. It's one of the most geographically widespread zoonotic diseases because it has different strains, and each strain can survive in different environments, although it's most common in humid, subtropical, and tropical climates. This climate relatedness can be seen here, as higher dengue-related disease-adjusted life years, or DALYs, are found in densely populated humid countries frequently hit by typhoons. So according to the Global Burden of Disease data from the Institute for Health Metrics and Evaluation, dengue-related DALYs per 100,000 people in the Philippines was higher in 2017 than in 2010. Now, there was no available GBD data on leptospirosis, possibly due to underreporting, lack of diagnostic resources, or difficulty of diagnosis given its similarity to other infectious diseases. But warm, humid, and heavy rainfall areas report higher cases of dengue and leptospirosis. But literature shows that disease trends highly depend on the study setting. So this means local evidence is important to understand the relationships, yet local climate and dengue or leptospirosis studies in the Philippines are few and far between. Now, the Philippines, a tropical country in Southeast Asia, is especially conducive to both dengue and leptospirosis. Its average annual climate is warm and humid throughout the year, with varying flood risk across the country. Quezon City is located in Metro Manila, the country's capital region. It's a highly urbanized and densely populated city with warm and humid climate and moderate to high flood risk. Now, given the likelihood of Quezon City having good conditions for the diseases, this study aimed to assess the situation using the US CDC's Building Resilience Against Climate Effects, or BRACE framework. To do this, we used time series and spatial analysis to determine the magnitude and distribution over time and space of all the indicators. We then used generalized linear mixed modeling to determine the association among the exposure outcome relationships. And lastly, we used seasonal autoregressive integrated moving average, or SARIMAX, and support vector regression to forecast the following year's disease burden. Now, due to limited data, the last objective serves only as a proof of concept. Now, trends showed that dengue and leptospirosis cases peak around the southwest monsoon season. Dengue showed higher variance in yearly seasonality, while leptospirosis showed smaller variance, but there were fewer cases overall. Now, local climate projections show that increasing intensity of tropical cyclones. Now, this may affect disease rates and variance. The disease troughs also occur at hot and dry months, suggesting either a lagged effect from high temperature or a maximum temperature threshold. The multivariate machine learning disease forecast for 2018 showed less dengue and lepto cases in QC, but peaks still occur around the third quarter of the year. Now, due to lack of publicly accessible city information, we haven't yet confirmed 2018 case rates. However, the following year, QC actually reported around 22% less dengue cases in 2019 than 2018. So there may be a decreasing trend for dengue. Now, we use the local indicators of spatial autocorrelation, or LISA, to detect disease clusters. And 3 dengue hotspots and 5 leptospirosis hotspots were identified. Only 2 barangays were overlapping across diseases, but no significant double burden was found. Hotspots and high case areas surrounded by low case areas should be monitored for interventions. Overall, spatial analysis may be more accurate if more granular spatiotemporal data was available. Finally, the disease model showed relative humidity was the only predictor for dengue, at 2 additional cases per 100,000 people for each 1.72% increase in annual humidity. Now, July 2012 recorded the highest dengue incidence for the whole study period, and the same period recorded 34 degrees maximum temperature and 92% humidity, which supports the model results. This is also consistent with another study in the Philippines by Lorenzo et al. In 2011, and in a study in Brazil by Costa et al. In 2010. On the other hand, all exposure variables were significant predictors for leptospirosis, with maximum temperature having the greatest effect. The most curious result was the inverse relationship with rainfall at 1 less case per 8.33 millimeter increase in annual rainfall. Now, this may be due to the coarse granularity of the data or the fact that we didn't include other modifying variables like age, sex, or a flood model. Now, given the results of the study, we suggest 3 sets of recommendations: policy, action, and research. For policy, standardized, streamlined, and centralized health data across all health facilities and with the Department of Health should be improved, possibly through further developing e-health for the Philippines, as this can make it easier to centralize and digitize data. Now, the health aspect of national and local climate and disaster resilience plans should also be supported by evidence-based health impact research like this project. For action, we recommend conducting more regular communication campaigns on dengue and leptospirosis, such as providing information on the climate drivers and proper preventive measures. Now, the high case areas or clusters identified in this project should also be monitored for the climatic factors, which could help develop targeted local interventions. Now, we also recommend studying the disease and prevention protocols in low case cold spots for actions that other areas around them can adapt. And lastly, for research, we recommend exploring mixed methods and other variables in climate disaster and disease, such as looking at NCDs, flood models, or drought models. Now, other machine learning methods in multivariate disease forecasting can also be considered for local intervention planning. Lastly, we recommend conducting further action research using safe spatiotemporal techniques, like in this one, to develop proactive co-benefit solutions to climate and health, particularly given local climate projections. Now, disease is one of the most personal, yet least explored impacts of climate in the Philippines and should be given more research support given current climate trends. Now, this ends my presentation. Thank you for listening.
Thank you very much, Kathleen, for that presentation. And so now let's go back to Latin America. And we have with us Elaine Flores Ramos. She's from the Center for Global Mental Health at the London School of Hygiene and Tropical Medicine in the UK, and also part of Emerge, which is a unit at the Universidad Peruana Cayetano Heredia in Peru. And she has a PhD in epidemiology and population health. And she will be talking about the mental health impacts of El Nino in Peru. And so, Elaine, you may now begin your presentation. Thank you.
Everyone, and thank you for your time for attending this presentation. My name is Elaine Flores. I am a female Peruvian researcher. So I will be presenting briefly the main findings obtained in the quantitative and qualitative components of my PhD research, which explored the impact between the recent El Niño events occurred in the northern coast of Peru and mental disorders and psychosocial distress. So we are under an undeniable climate emergency, which has impact over the frequency and the magnitude of cyclical environmental phenomena as El Niño. So this environmental phenomenon will lead to periodic extreme weather irregularities, causing floods, landslides, and intense precipitations in the coastal areas of the equatorial Pacific Ocean. So there will be an unequal risk exposure and vulnerability across low and middle income countries to this type of events. Sorry. In 2016 and 2017 occurred an El Nino event, which was strong and caused overflowing rivers, flash floods, and mudslides. There were quantitous damages reported over all the Peruvian coastline, which is also lead to over 1.83 million people affected. So in this context, we studied the effect of the phenomenon of El Niño in the communities in the northern region of coastal Peru, in Tumbes. So a few facts of Tumbes. Here we can see its location. By 2016, almost 30% of the population had at least one basic need unmet, and almost 60% of the houses were built with rudimentary materials, and almost 40% lacked a public water supply and a drainage system. So for the quantitative component, we did a secondary data analysis. We used the individual level data from a 3-year pragmatic stepwise cluster randomized trial, which in each participant was evaluated at baseline and every 5 months in 6 follow-up visits. And depression cases was the main outcome and was defined with a PHQ-9 score of equal or more than 5. We developed a conceptual framework based on some priori set of confounders. And the main exposures were the extreme precipitations and flooding events related to El Niño. And also some impact variables were the houses damages, the affected persons, and crop losses. Some baseline sociodemographic factors were considered to be potentially associated. And we included longitudinal data from adults from residing in 6 villages. What we saw was that the baseline depression prevalence decreased steadily across the study visits, and the unadjusted odds of air temperature, mean superficial sea temperature, and crop losses were associated with developing depression in the follow-up period. However, in the fully adjusted model, it was not possible to estimate the associations that support the hypothesis that El Niño affected depression rates on the study participants. This may be because of we included mild depression cases, and there was also the possibility of a spontaneous remission of depression, and that there were milder than expected El Niño effects. Also, there was the possibility of some resilience promoting factors that we did not measure, and also a sustained marketing campaign to facilitate the study intervention. This may have influenced these findings. We also conducted a qualitative component in the same area. We aim to describe the perceived effects of mental health, and which were the barriers to achieving psychological well-being and accessing support in a post-El Niño scenario in the same region. We conducted interviews and focus groups, which were classified within these 4 subgroups, and we analyzed the data using a thematic approach. Are the 3 interrelated pathways that were found across the interviews and the focus group discussions. I will now summarize the main findings. So the overall impact of El Niño effects on mental health at first was minimized by some participants who suggested that as this area was historically affected, they were accustomed to them. However, most of these responses changed later, when there were described some specific witness of suffering and socioeconomic struggles. Also, the psychosocial distress was exacerbated by poverty, the scarcity of work, and detrimentally was affecting vulnerable groups. There were no availability of therapies or community-based support programs reported. And the study findings also highlight that there were multiple and interrelated issues associated with under-resourced communities in this context. Also, that we should be providing emergency aid and health support in addition to vulnerable communities, that also will be requiring integral care and resilience approach that also considers socioeconomic, psychosocial, and community level distress, including improved access to prevention measures and prompt reconstruction activities. So all the residents' problems were deeply interrelated with a pre and post-disaster context. So we believe that the response and the treatment care approach should be in line with these needs. Finally, I want to highlight these take-home messages. First, that the results in both components suggest that maybe it may not be always possible to obtain a direct measurable effect related to the phenomenon's impact on a common mental health outcome. Second, that these effects, especially if left untreated or unsupported, may have a significant negative impact on the well-being at both levels, at individual and community level factors, which in turn will contribute to contextual factors as suffering, despair, and lack of trust within communities and with their own authorities. Many thanks for your attention.
Thank you very much, Elaine, for that talk. And now, before I proceed calling our last speaker, again, I would like to encourage our participants. I know we're not a very big group here, and so I'm really encouraging you to please send in your questions or comments using the Q&A chat box in the platform. So that later we can have a really lively and interactive conversation. So now, may I call on Emmanuel Mawuli Abalo. He is a Master of Science graduate of University of Oxford in Environmental Change and Management. He's a social, environmental, and health scientist. And he will be sharing his study on trends and projections of temperature and heat stress in Ghana from 1980 to 2050. Emmanuel, please, you can start your presentation now.
Good afternoon. Thank you very much for the opportunity to present at a safe Global Virtual Symposium on Health Systems Research under the Climate Changes Health, Emerging Disease, Trends for Reorienting Health Services session. I am presenting today on the trends and projections of temperature and heat stress in Ghana from 1980 to 2050. The negative effect of biometeorological variables on human health has been acknowledged throughout human civilization, and progressively detailed accounts on the causes of climatic changes and the vulnerabilities and its impacts on human health have since been reported. But reminiscent of past reports and recently reflected in major reports such as the IPCC, detailed information on the biometeorological impact from climate changes in developed countries as compared to less developed countries, thus leading to an alarmingly incomplete and perhaps an inaccurate understanding and appreciation of how climate impacts are affecting different people across the globe, especially in Africa. But the African continent presents an interesting case in regards to heat stress, as it does not take much for temperature to reach life-threatening on the continent. Yet, to date, no one knows how many people have been have died or have been severely impacted in other ways by extreme heat in the African continent because one, the impact have been poorly tracked. Two, there are biased reporting of climate change in the international community and emergency databases, such as the Emergency Event Database. Three, the lack of high quality epidemiological and climate change data. And four, the erroneous assumption that Africans have acclimatized to increasing temperature and relative humidity, and that in comparison to their counterparts in temperate communities. But it is not the case that Africans are unaware of the impact of heat stress. Rather, this problem stems from the underreporting of scientific studies that's in the African continent that's silencing the voice of the continent, which has been metaphorically described as the canary in the coal mines when it comes to climate change impact and its climate change impact on societies and human health. So to contribute to bridging the existing knowledge gaps in our understanding of heat stress and its health implication in Africa, this study basically used long-term temperature and humidity information from a novel set of high-resolution and sample-based regional climate data that was performed as part of the WASCA program for continental West Africa. Now, the study objectives are in two. The first one is to present the variations and trends in temperature and between the historical, that is 1980 to 2009, and the near future period from 2020 to 2049. And two, to quantify the exposure to heat stress in line with climate change using the National Weather Service heat indices and its associated health implications. Now, to undertake this objective, I used one reanalysis data set and 3 regional climate models that were performed as part of the WASCA program. Now, although air temperature and humidity are just two among a large array of factors such as physical activity, clothing, the water that we take in, and the salt intake that contribute to heat stress in humans, air temperature and humidity are the two factors that many people have little and in some cases no control over its regulation. Therefore, having knowledge about these temperature and humidity variations are relevant and also critical for adequately preparing for when heat stress will occur and how we'll be able to overcome these heat stresses, knowing that in Africa and in Ghana specifically, temperature is a key indicator of climate change. So as can be seen on the screen, our analysis found a moderate warming between the two periods with significant monotonicity, and specifically, within the historical period, temperature increased between 0.2 and 0.9 degrees Celsius, whereas the near future, it is estimated that it will increase between 0.5 and 0.9 degrees Celsius. So this in a way gives us an idea of the fact that in the near future, there will be more warming conditions in Ghana in comparison to the reference period, that is 1980 to 2009. Now, the increasing annual mean temperature between the two periods, and more importantly, in the near future period, is quasi-linearly related to more warm days and heat episodes, as will be seen in the occurrence, frequency, and intensity of heat stress in the next slide. Now, the safe and caution categories decreased in both periods, whereas the extreme caution category increased over the steady period, but with a pronounced increase in the future period. And specifically, as you can see from the screen, the caution category of heat stress in the near future would decrease from the historical exposure of 211 days to 144 days, whereas the extreme caution category will increase from the historical exposure of 90 days to 144 days. And there was no year within the near future period where the exposure was less than 120 days per annum. And these exposures comes with certain health implications such as heat cramps, heat exhaustion, and heat stroke among the population. So the study findings have several implications. But then in summary, in regards to reusing the WASCA data set, it allowed us to undertake a more reliable prediction of the potential climatic impact on human health and the regional dynamics in such exposures. By doing this, it helped to nuance our understanding and appreciation of the extent to which prolonged exposure to heat and warming conditions could exacerbate the risk of heat-related morbidity and mortality, as well as cardiovascular and respiratory diseases in Ghana. But the window of opportunity to act in reducing the health impact of heat stress in Ghana is still open. But then this needs to adopt contextualized policies that cut across the different streams in Ghana and also try to incorporate public sensitization in our educational spectrum. And in conclusion, avoiding heat stress is easier said than done. And it will take concerted effort to avoid, if not reduce, one's exposure to heat stress and its associated health implications, especially in the steady context Ghana, where approximately 90% of the steady population or of the populace are involved in the informal economic sector. So I do believe that adopting such strategies will be critical in our effort to reorient our health services and health system infrastructure to make it proactive in responding to the multiple effects of climate change on health outcomes and emerging diseases in the 21st century. Thank you very much for your time.
Thank you very much, Emmanuel, for that presentation. And now I would like to invite our 5 amazing panelists to join me. And for the next 30 minutes, we'll have a conversation. We have several comments and questions in the chat box, in the platform. And let's have an exchange of ideas and figure out how can we actually use this knowledge that we just shared to really influence future health systems. If you were in the plenary, the opening plenary a while ago, they just launched, or Health Systems Global just launched this new initiative around reimagining health systems. And so it seems that now we're realizing that climate change is going to be one of the leading drivers of global population health in the years and decades, if not the century to come. Then certainly this key driver of climate change, along with its wide range of health effects, will need to be considered in the redesigning of health systems that not only respond to the health problems, but ensure that there's equity and justice for all. It's amazing to be hearing all your presentations. We captured basically the entire planet, or at least what we want to call the global south, from Uganda and Ghana to the Philippines, in Asia, to Peru, and actually the whole of Latin America and the Caribbean, as covered by Ariel. We also were able to see the wide gamut of health conditions that will be affected by climate change, from infectious diseases like malaria and dengue and leptospirosis, to heat-related illness, as Emmanuel was showing, that the temperature or the average temperature is both increasing in terms of direction, but also increasing in terms of variability. And so these definitely will need to be considered as we plan for health in a warming planet. And of course, our presentation from Latin America as well look at overall mortality, including the ones that are resulting from natural disasters. And of course, I think one of the neglected children of climate change and health is mental health. Because, and then maybe later, Elaine, you can give comments as to how can we really think about mental health in the context of climate change. Mental health is now gaining traction globally as a new agenda, for instance, in non-communicable diseases. We always say NCDs are about cardiovascular, cancer, diabetes, and now mental health should not be forgotten. And it seems, based on your study, mental health has very strong links with climate change as health. So how do we think about these pathways? There's a question in the chat box from Mohammed Azmal Hossein. He was asking, it would be excellent if someone can also talk about the implications of climate change on sexual and reproductive health. And so I really like that question, because now we're starting to ask, how are these diseases, these disease conditions that already exist in the pre-COVID or pre-climate change world, how will these be affected? And so, if you have some comments as to some of the things that I mentioned about, mental health, for example, for Elaine, uh, what is the evidence for sexual and reproductive health, or what are the gaps? What are the issue areas that we need to look into as well. So Elaine, do you want to start about mental health?
Yes, thank you so much. Well, actually, one of the things that was noted during our study, which are linked with the adverse context that is posing already and will pose much in the future of climate change, is that cyclical environmental phenomena as El Niño will just be adding to this context. We will now be on the pathway, hopefully, to recover from COVID, but that is another factor that has helped out to show the true magnitude of our unstable systems that we have and the disadvantages that everything brings to already vulnerable and marginalized groups. So disproportionately, we will have groups that will be much more affected by mental disorders and mental conditions, and they will lack the support to reach, let's say, like a real resilience and to be able to reconstruct and rebuild their lives. Therefore, what I think is that the efforts to promote this well-being, resilience, and to be able to increase this support, decreasing also the psychosocial suffering associated with these disaster and external threats, should be considering this two-level perspective. Not only not only to be able to address, for example, at individual level, um, access to mental health support, but also to be able to rebuild communities. So we have factors that are working at the social and ecological levels in affected communities in post-disaster settings that should be also being considering.
Thanks, Elaine. Anyone who would like to add, not necessarily to mental health, but also to these bigger prompt that that I just started with. This is exciting because in Health Systems Global, the environment is not very much talked about. I remember when we were in Liverpool 2 years ago during the closing panel, I actually raised it, my observation that out of like nearly 2,000 abstracts in the whole conference, only one actually mentioned climate change in the abstract. And so it's amazing that now we have our own panel. We actually have several in this year's, the sixth global symposium. We need more. And so in a way now we're trying to advocate to the health policy and systems community. Let's now give attention to climate change as well, in the same way that we look at the other forces that shape health systems, whether they're commercial determinants or gender or culture or politics. The environment is also important, perhaps one of our blind spots in health policy and systems research. Anyone else who would like to comment about these general themes? The interesting thing is this is a very mixed group. I believe some of us, and I just want to highlight Javier de Bethune. He mentioned that several of you are geographers or colleagues from other professions. You're not necessarily. I think it's Emmanuel who's not necessarily a health professional. Although I would argue that every professional is a health professional, as now we're realizing in the age of COVID. So maybe you can speak about any thoughts on how can we work together, health policy and systems researchers, as well as other scholars and from other disciplines to make sense out of these issues. Emmanuel?
Okay, thank you. So just to reiterate the point that you just made earlier, I think even conversations on the the relevance of the environment and climate change specifically on health, I mean, it's kind of fits into the wider consideration of what actually goes on within the IPCC, where historically since the 1990s through to now, it was, I think, just AR4, and that is when they started talking about the impact of climate change on health. So, I mean, this has been a yawning gap within the academic and scientific literature where people do not really consider that once you find yourself operating within an environment, inadvertently, you are being affected by whatever it is that goes on within the environment. So I think in helping us to collaborate in helping to come up with a system that are robust in treating the 21st century diseases, it is then needful for our policies to also consider people who are within the academia. I mean, coming up with people who are working within the health systems, like having medical doctors around, also collaborating with people who are into climate change issues, also trying to collaborate with people who are into epidemiology, trying to find out how can we really come up with policies that will be able to help strengthen what you're trying to face. Now, using the example of what I did for my master's dissertation, I noticed that climate change conversations in something that is really considered across the country. So you tend to speak with people on the impact of climate change on their health, and they feel like, oh, I'm already living in the tropics, so I'm used to high temperatures. But that is not actually the reality. It's because we've not really educated the populace on how increasing temperatures could affect their health. So there is this myth around temperature not really being a major indicator. So linking that one to what Anne said on even malaria cases, and looking at how the impact on even mental health, also linking that one to what Sia reported in the case of Uganda and what Roberto was also mentioning, you do realize that there is a need for us to come up with that education for our populace, for them to know that there is a need for us to keep considering these things, so that in respect of the profession you find yourself, the field you happen to practice in, you still try to introduce such conversations to the people you tend to meet. And by so doing, there will be that trickling effect for people for the attention of everyone to now be drawn to the impact of climate change on their health. And I think that could be a conversational opener.
Thanks, Emmanuel. Now I would like to ask Kathleen, because I'm aware of CICAR, the CICAR project in the Ateneo University, very multidisciplinary project.
Yes.
I wonder how, because we also have some questions about multisectoral approaches. My friend Rachel Dusom, hello to you, asked a question about, for ministries of health who have limited control over factors contributing to climate change, what multisectoral policy and advocacy approaches would the presenters recommend? And, I guess I want to connect it to Kathleen's experience. How are you able to bring health to these very multidisciplinary and cross-sectoral endeavors? Because now health is, in a way, just one of the many. You have environment, you have agriculture, you have energy, all these other sectors that are related to climate change. So Kathleen?
Yeah, so for those who don't know, the CICAR PH project is the Coastal Cities at Risk project, and it involves academe from different fields. We have climate scientists, we have epidemiologists, we have innovators, technology innovators, and we also partnered with local governments. We have, I think, 5 now or more than 5 local governments all around the Philippines. And we partner with them through gathering data or coming up with solutions that are innovative in technologies or are relevant to their communities, that are, how can I say this, already existing capacities to be resilient towards climate and disasters. So we all work transdisciplinarily. So we have different people from different fields without any tendency to work in silo, because I think that's the natural tendency for most scientists or researchers, is to work within your field, but that's not what planetary health is becoming. We have to work with communicators, we have to work with geographers, we have to work with public health practitioners and climate scientists, impact sector specialists, and most especially the community. So that's actually the forefront of the project, is to work with the community to find out what's relevant in your place, in your area, in your locality. What is your experience of climate and disasters? What have you done and what can you still do? How can we help with that with our scientific knowledge or our more positivist or empirical knowledge, to be paired with your lived experience in disaster and climate change. So that's actually one of the next projects that we're going to be doing in Epimetrics, not necessarily the CICAR project, but with Epimetrics. There's an upcoming project that we just received funding for on assessing the climate related disease burden in different provinces in the Philippines. So a whole lot of that's a whole list of disease burden in the Philippines that are relevant to each province. But we are also going to be partnering with climate scientists because we need the historical and observed climate, but we also need the projected climate data. So that's some effort towards it. And also the global burden of disease for 2019 was also just released, the report by IHME. And if you look at the data for the Philippines, about 11 of the risk factors for all the disease adjusted life years for 2019 were actually environmentally related. So you have ambient air particulates, household air pollution, secondhand smoke, unsafe water, occupational injury, high temperatures, hand washing, unsafe sanitation. You can even expand it to high blood pressure and diet-related risk factors, particularly during disasters. But we don't have a dearth of literature or studies in the Philippines about these things. Most of our local literature is actually just focused on what you've said before, on infectious diseases. It's mostly dengue. We have a few on diabetes, I think, and some cardiovascular diseases, but they're also very general. We haven't explored by priority of how big is the disease burden of this particular disease, or how large is the contribution of this particular environmental related risk factor in the Philippines, and why won't we prioritize our research based on that, and then we can therefore prioritize our policies or our climate change adaptation and disaster risk reduction policies based on the evidence on planetary health research.
Great, and it will be great to have a separate conversation between the two of
Yes.
us to how we can collaborate in addressing climate and health, planetary health in the Philippines. It's also important to just acknowledge Kathleen is also a geographer. She's doing a master's in geography, but very well versed in the global burden of disease. So it's quite fascinating, and that is an encouragement to our health policy and systems researchers in the room to start working with all these different disciplines where we can, which are vital in trying to really unpack these complex interconnections between the climate and health. I really
Sorry,
also like what you
sorry,
said
I would just
about.
like to add, actually, sorry,
Sure.
to what Emmanuel said earlier about communicating
Yeah.
with the communities themselves, the experiences and the vulnerable communities. My undergraduate is actually communication research, so it's
What?
another field that's different from public health and also geography and climate science.
Right.
So I've found that maps are actually one of the most useful tools for science communication, particularly for local governments, at least in the Philippines, based on my experience, because they have flood maps, risk maps, hazard maps, and that's also one of the more digestible ones for mass communication. So I think we could explore using maps or that type of data visualization, as opposed to logistic regression graphs and line graphs and exponential growth. Yeah, we could explore different data visualization for science communication.
Right. Excellent. You're a Renaissance woman, and communication is also vital. You mentioned a while ago as well the importance of working with the communities. I just want to share my doctoral dissertation is actually half written and half film, because I also wanted to make sure that the emerging health impacts of climate change in coastal communities in the Philippines and the perceived impacts based from accounts from different stakeholders are really captured and not interpreted by my intellectual brain. And so those films are actually in YouTube. I can share it with our colleagues later on. I want to bring in Ariel and Sia as well. Really great conversation we're having here about community and multidisciplinarity in coming up with climate and with a better understanding of climate and health problems, but also in generating climate and health solutions. When it comes to research, how are you able to navigate, data? I think we have some questions about data. We have a comment that, one of the main problems is really data quality and availability, especially in developing countries. Elaine and Kathleen also use a lot of data in their research, but I want to hear from Ariel. You used data from across the Latin American Caribbean region, and then Sia, you look into Uganda, malaria data. How are you able to navigate these usually fragmented and relatively thin information systems to be able to come up with a study that such as the ones that you presented? Who would like to start? Ariel, I saw you unmute.
Yeah, okay. Thank you, Renzo. Well, I would like to highlight some issues about data. I think Kathleen's dissertations and I have some points of coincidence regarding the issues of data. Availability and quality of data need to be improved, especially for health data. Regarding climate data, well, there is availability of climate data. We could create the trends, and also we can build the projections for climate data. And this is not so hard to do, but when you can when you are going to find the data about climate-related diseases, there is two major issues. One is the criteria for defining climate-related diseases. Which criteria do you use? And the other major issue is the availability of data. If you wish to perform a global study, you come to another troubles because availability is not for all countries. But if you want to make some local studies, well, you can also have some issues. But yeah, I mean, data is a crucial issue. I think that policymakers have to pay more attention for data. For example, today in Mexico, we have more than 140,000 people affected by the floods generated by Hurricane Eta. And those people probably have no conditions for keeping the healthy distance, the social distancing, the hand washing issues and else. And probably they will be exposed to transmissible diseases, and they will not be attended as well.
Thank you so much, Ariel. How about you, Sia? Any additional insights with regards to data, but also the other themes that we discussed about working with other sectors, listening to community voices, etc. Sia?
Sure. So thank you so much. Building on what Roberto said, I think there is a really big problem with data sharing. Like for Uganda, we have different ministries are responsible for collecting data. We have the Ministry of Health, we have the Ministry of Gender and Social Development. So they collect their data, but they don't share. So in fact, I, as a researcher, I have to go to each of those ministries and buy data. So I pay money to get data, Then I go to the other ministry, I pay money, I get that data. So there is no sharing, there is no synergy of the information gotten from the ministries. Now the data which can be easier to get is if you go to the households, you interview them, there you can get some good data easily. But even the process to get there, you need to do ethical approvals. You have to follow a whole process to collect that kind of data. So at the end of the day, the quality is compromised. But all in all, I think the major point is we really need to work together. Thank you.
Thanks, Emmanuel. We only have around 9 minutes, and I just want to read some of the remaining questions, and then perhaps we can try to answer them together. But all of them are pertaining to, the how part. What do we do next? We have heard about climate and health, the different challenges, the different diseases. Every country has its own unique vulnerability. We have a question from Mariami Beridze. What are the tools for assessing climate change impact on developing emerging diseases? I think we've seen an array of approaches from using existing data to, I think, qualitative research as well, because Elaine did qualitative analysis interviews. Kathleen also mentioned the importance of downscaling data, because a lot of these climate and health projections are done usually up to the level of a region or a country. But how can we make such data more tangible for local communities as they prepare and plan for climate-related health impacts? Ikena was asking about improved technologies and innovations. And Tolib Mirzoev also was asking, what are the experiences and evidence of effective solutions, particularly related to neglected issues such as mental health, which Elaine already mentioned, or even system-wide challenges such as corruption. So, is corruption also linked to this issue of climate, health, and perhaps cross-sectoral corruption as well? So many issues. I think let's spend the last 7 minutes thinking about the future. What do we, if we're going to encourage our colleagues here, again, from the field of health policy and systems research, what do we want them to bring home and to start with in terms of building climate resilient or climate ready health systems? So I'll give you all a chance to speak and let's try to be brief and direct. Anyone who would like to start? Sia.
I can start. Thank you. Okay. So I think my major point is health systems should be built in such a way that they put a lens of climate change. They should be able to respond to climate change events, either at the local level, regional, at global levels. So they should cut across. Thank you.
Thanks. And maybe I'll go to Kathleen next.
Yes, I definitely agree with what Sia just said. It's to work across the levels and also across sectors, so that basically, essentially, we just want to work together across different disciplines so that we address all possible angles, but also we also work with different levels so that it's national level, but also specific to the community level down to the household level, so that we address every possible problem along the way. It's hard, but it's our ambition.
Great, great. And I agree with the multi-level approach. Oftentimes when we talk about climate change, oh, it's a global problem, let's leave it to global governance, when in fact, even regional governance, and Ariel talk about, Latin America, one potential entry point is, what is the role of regional bodies and the WHO's regional offices in trying to address these shared regional issues, and then all the way up to the local level. How about Emmanuel?
Okay, so I think just 2 points. The first one is there's a need for us to contextualize our climate change communication, because as you did mention, we tend to have this global conversations of climate change and the impact that's on people, but then you go to our local communities and people identify with climate change differently. So if you're able to contextualize some of our communication to be very good. Then the third question that one of the attendant did ask in regards corruption, there was a study that we did in 2018 that was in fact tried to look at why there is large healthcare inaccessibility and disparity between rural and urban Ghana. And I think one of the key findings has to do with the fact that corruption contributed much to the health disparities across the countries. So I think if we will be able to have conversation with our national governments where more resources are being dedicated to research, it would help to bridge some of the data gap we tend to have in the global south. Because I do not really see the need why you'll be accessing data and should be paying more money for it. But then if systems are in place and the money that is needed are being funded, are being directed towards those studies, it will be quite easy for researchers to get access to it, come up with relevant studies where they can collaborate with medical doctors and other professionals to come up with policies that help to strengthen their local communities. Yeah, thank you.
I really like what you said about contextualizing and localizing the storytelling of climate and health. And actually, we have one question from Vanessa Ofyong. She was asking, how can journalists use the information that you've generated? How can they use it for their media reporting? And so you just gave a very concrete advice, talk about the local as we try to raise awareness about a global issue such as climate change and its health implications. I think we lost Ariel. He mentioned a while ago that he has connection issues. And so maybe Elaine, you have the final word. What is the way forward in terms of incorporating climate change and health in health systems planning and operations? Elaine, you're muted. Yeah, that is the new slogan
I'm so
in the
sorry.
era of Zoom. You're muted.
Yes, absolutely. Well, first of all, thank you for the opportunity to. I think that I completely agree with my colleague panelists have mentioned working in across levels and across disciplines is very important. I would also add that is really necessary to try to build trust with the authorities, also working at grassroots community level. Um, because of, and I will just mention a local example. For example, now in my home country, Peru, recently there has been another political crisis, which seems that is like something that completely is in a continuous fashion. Is really sad, but that also shows that all these protection and preventive programs that should happen at the state level and maybe at regional level will not almost never happen because despite we have the policy, there is still continues having a lot of corruption across institutions. And in global health and in health systems, that is really important. So I think that another way that we can go is to well, to strengthen the civil society, strengthen and empower communities to be able to organize and also to keep some sort of bridge with their authorities and to be able to reach the changes that are needed.
Thank you so much, Elaine. And I think that's a wonderful way to end this conversation, the importance of mobilizing our community, civil society to really take climate action and to highlight the inextricable link between our planet's health and our own health. And so again, thank you to all of you for your amazing contributions. And I really hope that this is just the start of really putting climate change and the environment front and center in the agenda of health policy and systems research. So again, thank you everyone. Thank you to our participants. Thanks for your questions and enjoy the rest of the conference. Please stay safe.
Thank you
Goodbye.
so much.
Thank you.
Good night.
Thank you.